It's 5 o'clock for me in California. I know it's 8 o'clock for those of you on the East Coast and various times in between, but we'll go ahead and get started. So thank you all for joining us. This is our webinar tonight, Intro to OBGYN Research, and we are the ACOOG National Student Society, or NSS. We'll just go ahead and introduce the board. I know not all of you were able to attend the roundtable last time. This may be your first time meeting us, so we'll just go ahead and introduce ourselves, those of us on the board that are here tonight. My name is Pooja. I am the president of NSS this year, and I'm an OMS2 at Touro University, California. And then I see Rayleigh, so I'll ask you to go ahead and introduce yourself.
Hi everyone, I'm Rayleigh Abel. I'm a third year from LMU DCOM, um, and I am the social media chair for the board, and I'm currently rotating in Western Kentucky. I think Andrea is on here as well, if she
Yes,
wants.
hi. Hello, my name is Andrea. I'm a third year at the Kansas City University Joplin campus. I'm currently in New Jersey, New York area for my rotations, and I am the secretary and treasurer this year.
All right, I'm not sure if anyone else is on board here. If you are, speak up. Otherwise, I'll go ahead and move on. Okay, all right, I will move on. So we do have a wonderful guest speaker tonight, Dr. David Jaspin. This is his bio here, which I'll read. So Dr. Jaspin is the Chief Medical Officer at Jefferson Health Plans, a board-certified obstetrician gynecologist, and clinical professor at Thomas Jefferson University. He previously led the Department of Obstetrics and Gynecology at Jefferson Einstein Hospital and has held extensive quality, safety, and leadership roles across the enterprise. His national contributions to graduate medical education include chairing the ACGME OBGYN Residency Review Committee and serving on multiple milestone work groups. An award-winning educator and distinguished fellow of ACOOG, Dr. Jaspin has authored numerous peer-reviewed studies on obstetric safety, decision-to-incision performance, and COVID-19's impact on maternity care, and he is a frequent invited speaker on obstetrics quality, education, and health equity. So that's Dr. Jaspin. I'll kind of go over our agenda for tonight. I just have a few slides I'm going to go over just talking about research and why it's important in OBGYN. But most of this webinar tonight is going to be with Dr. Jaspin. He's going to share his story, his expertise, and then we'll have time at the end for a Q&A. Okay, so our goals for tonight: understand why research is important in OBGYN, learn about the different types of OBGYN research, know how medical students can get involved, understand how to find mentors and projects, and feel more confident starting your own research journey. So why research is important in OB-GYN. Research really drives progress in women's health. It was only really within the last couple of decades that women were even included in a lot of clinical research. So there's a lot of catching up we need to do. But research in OB-GYN has led to many things, including improved maternal mortality prevention strategies, advances in fertility treatments and reproductive endocrinology. There's better screening and treatment for gynecological cancers. We have safer contraceptive options, and there's improved surgical techniques and minimally invasive procedures. These are just some of the things that research in this field has led to, but there are still major gaps in women's health research, which is why it's really important we all get involved. And there's a lot of benefits for medical students. For us, it gives us a deeper understanding of clinical problems, helps us to develop our critical thinking skills. There's a lot of opportunities for us to publish and present on our work. It does, help with residency applications, and it's exposure to academic medicine for those of us that may be interested in that area of OB-GYN. But ultimately, research will help us contribute to improving patient care. And there's different types of research. So there's clinical research, there's public health research, including epidemiology. Basic science is what I think many of us may think of. Translational research, And there's medical education research, so how we can improve medical education in OB/GYN. There's quality improvement projects, and there's also community-based research. So this was just kind of the primer I wanted to start with for the webinar, but I'm really going to turn it over to Dr. Jaspin. So I'll stop sharing my screen here and really turn it over to you, Dr. Jaspin, to share your expertise.
Sure, thank you. So first, I want to thank Pooja and ACOG for putting this together. This is really important. It's important because though there are equalities that we see now from allopathic to osteopathic residency training, there are significant deficiencies in osteopathic training in this space. And that's not because of anything other than the structure. And so the structure at Jefferson is an academic institution. And I'm fortunate to be there and be part of that. And that's where I spent my entire career. But I want to tell you a story. So I went to PCOM, Philadelphia College of Osteopathic Medicine, PCOM. I did my internship there. I did my residency there. And like, I didn't do a single stitch of research. Maybe I did a case report, maybe. And then I was fortunate to come to work at a community-based hospital in a very underserved area. And they had an allopathic residency program. And I can tell you that that was in the year 1999. So no further comments, please. But I remember my very first morning report, where there was the program director, the vice chair, the director of GYN and maternal fetal medicine. And there were 4 residents per year, and every single one of them was there. Nights didn't matter, you were there. And I was like, whoa, this is not how I trained. I trained by the person older than me in residency, sort of told me what to do. And occasionally an attending would drop me a pearl. But that's not how I trained. And I was exposed to something very different. And it was enlightening. And I now have a research portfolio that is great, but it's not on me. It's really not. My career path was through traditional academic medicine. I became the clerkship director, the program director, the vice chair, the chair, etc. And you progress. But what I was able to see is the impact of research on our community, on our residents, and our applicants. So I can speak to it and will speak to it in full circle. And so getting research done is nice. The carrot is your name's in publication.
Yeah.
Like your family, your friends, your partner, your parents will be so happy and impressed. But it's one. It's one. But the amount of effort and time it takes to get that one peer review publication, it could be 12 months, it could be 18 months, it could be longer. And so what I want you to begin to think about is completing research, because it's nice to go to an interview, or it's nice to present yourself to somebody and say, I did it. Not it's in publication or I'm working on it, because that's nice and it might be what you have to do. But what I find very frequently in junior researchers is you have amazing, amazing ideas that probably require an NIH grant and a career. And you can't get there. I mean, you could, but not in this sense. And so these grand ideas of I want to do whatever, the magic is being able to break that down into something that you can actually accomplish. It might be the small piece of it. So what we try to do, let me just pause for a second. So when I was chair, we developed a research committee, we developed funding, and we put an infrastructure around research. And so every one of our residents has funding. They have a mentor. I edit. None of this is intended to talk about me. I'm just giving you what could be available. I edit, the director of our research team edits, our director of MFM, our director of minimally invasive, and our director of CFP all are editors for major journals. So our residents give it to me, and I'm like, this is never getting published. And here's why. And I'm very brutally honest. In the operating room, I'll be a little bit kind and give them credit, but on a paper, I'm going to be like, this is not happening for you. And here's why. But we have put that in place over a decade to give people opportunity. And what we then do is our students who are rotating with us, second years, third years, fourth years, they start researching with us. It could be we have a paper that's almost finished and we need data entry, where we need the like formatting, which no one ever has time to do. And so we asked the medical thing, would you want to do it? And like that, I could do that like literally tonight, or I could do it before I leave today. But that's amazing because I will never get to it. Our residents will never get to it, but it's that finishing touch. And that person's name goes on that paper. They participated in that work. And so we really try to engage people in all facets. So here's what we do. It's got to be your passion project. It can't be like, I just need to do it because I need it on my resume. You'll hate it. You won't like it. You won't do a good job, like everything else. And so we want people to come forward with an idea. And it's really important that that idea could be, at the beginning, it could be grand. And it's our responsibility to work with you to hone it down to a completable project. And sometimes we complete it in segments. Like, let's do the pilot. Let's report it. Let's report it as a poster. Maybe you get an abstract. Maybe you get an oral presentation, and then let's expand it. Let's look at it that way. Or you can say, we reviewed a paper on, I don't know, make it up, HELP syndrome, but it was in a population that we don't care for. Let's reproduce that paper in our population. And okay, our population's not that distinct. It's African American, Hispanic, whatever. Oh, but you know what? We have a significant increase in Haitian Creole speakers. Let's do that study in that population. It's not stealing because I don't know that the outcome is going to be the same in that group of people based on their cultural differences. And so it's really about thinking very differently. You need not come up with some like Nobel Prize winning award research. You just have to get something that you can take from knowledge and concept to completion. I'm going to pause because I like to make it interactive. There are 25, 27 people. So if there's anything you want to ask up to this point, fire it up and I'll answer. Nope. Okay. So here's how we do this. The idea comes to us, and we meet with the particular person and we say, what is it about this that stimulated your idea? What was the interaction? What was it that you read? And let's pull that together. If it's a case study, here's an interesting about case studies. If the case study is too unique, it won't get published. Because think about that. You're like, oh my God, this is amazing. It never happened before. Oh my God, I got to publish it. But from a publisher point of view, we're thinking like, yeah, but who's it going to benefit in the readership? If it happens 1 out of 1 million times, can I utilize a page in the Green Journal or Gray for that if it's only never going to happen again? And so you really have to think clearly about that piece of it. So in a case study, then you have to think, all right, well, what was it about was it the presentation that looked similar to something else that it would enable you to spin it in a way, if the person presents with right upper quadrant pain and hypoglycemia in the third trimester, oh my God, they have acute fatty liver. But this person didn't. They actually had God knows what it was. So when people present with acute fatty liver, you can begin to think, let me expand my differential to crazy, this one crazy thing that happened. And so you can still use that case, but in a little bit of a different paradigm. A lot of the research that I personally did was in surgical education. So I did, before there was minimally invasive, before MIGS, I did like a pelvic reconstructive surgery fellowship. So my interest is in surgery. And so I'll just share with you some of the things that I did, which were interesting. So, and again, this is you have to get consent for all these things, etc. But we videotaped our residents in the operating room and not doing the surgery, actually. We videotaped them from behind to look at their body posture and body language and to see if they developed any differences over time about their comfort level being in the operating room. And all of you are students, and you're in the operating room, you're like, how do these people stand here for 4 hours? Like, I'm going to kill myself. How do they keep their arms up? Like, whatever. It's because we don't do any of that. If you watch the senior surgeon, the senior resident, there's constant movement. They're stepping back from the table. There's like pauses and breaks. There's like I put my hands, I take a sponge, put my hand on something because I thought I can't focus right now. And I know that. And I'll put my hand on something and I'll look around, start talking, asking questions, and I'll take it off and start re-going again because you have to see what you're doing. If you look at like second year residents, they are constantly going, 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 but they're without intent, without intent. It's like non-focused behaviors. It's like bananas. And then as you look at medical students, this is my favorite medical. Like when I scrub with our residents due to a C-section and there's no student, I say, I'm going to be the student. I take the suction and then you're like actually sucking where they're trying to actually cut, not where they were cutting. And they're like, could you move your freaking suction? But that's what they're trying to help, but they don't know any better. And so all the research that we did was how to train people surgically in their body language. And then it turned into ergonomics, etc. So it's really, you can hone in on any piece of it. And then we started thinking about if you're going to train people in a simulated environment, how do you train them for body language? And then that all changed with the robot, but it's not really because there's still things that you can do. And not everyone does robotics, and not every case should be done on the robot. And so we started thinking about it a little bit differently. And then there's negative research, which I want to spend some time on. It's hard to get it published, but it's important. So we did a paper. Um, so you're all like have the threes are preparing for, and the twos are thinking about, but interviews, right? So I wanted to see what was the baseline ability for students coming into OBGYN in laparoscopic surgery. So you remember those stupid box trainers where you pick up a bead and you move it to another tray, like simple, simple task. And so we had a consent form. We told the applicants this is not being scored on your interview. This is just to set baseline. So if you match with us, we know your original baseline, and then we can go fresh from there to see if interventions we're putting in place can help you to get to a place. And it was also serving as a zero milestone because we were interested in how we set up milestones for moving people forward in laparoscopy. And every applicant, we gave the whole speech, never going to impact you. It's like we're not even grading it. We put it aside, whatever. And we did it. We did it for every applicant. And post match, we matched. It was fine. Post match, we did a survey. What was the residents' feeling on that particular interview? And specifically, what was it about? What was their feedback on doing the laparoscopic simulation? Every single person hated it. Hated it. They thought it made the program seem overly competitive, and it made it seem like there was too much pressure. And so I'm like, oh my God. It never dawned on me. We were really intentional about it. There was nobody even in the room. The program manager was in the room so that she could proctor, like, this is how you do it, but no people were in the room. I thought we like rethought about how we could de-emphasize it. So I wanted to share that with the broader OBGYN community because I didn't want anyone else to ruin their interview sessions by doing something like this. So I tried to publish it in academic journals. I tried to publish it in research, traditional research, and then I tried to publish it in like higher learning journals. Reject, 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 reject. Fortunately, a piece of research is knowing people. Just going to put it out there for you. So as you progress in your career, you learn to have friends where you become somebody who has friends in the right place. And so I did. I had friends at ACOOG, and I said, this is my story. And we were able to have an oral presentation abstract, but we were able to get it out in front that way. But no one was willing to publish it, but I thought it was very important to share. And so even research that doesn't pan out the way you intend should be out there, but it's very difficult to get it published. I'm going to pause again. I'm going to try to pause like every 10 minutes. I'm putting the sponge on the abdomen right now, looking around.
Yeah, I definitely have some questions. Thank you for sharing everything you have so far, Dr. Jaspin. I'm curious for anyone that, is like a first year, second year, really new to research, um, how would they kind of go about finding a topic that they're interested in, and who could they reach out to? If, for example, like I know at my school, we don't have any OBGYN on faculty, so it would be hard for me to reach out for an idea. And I'm sure there's probably other people on the call who are in that position as well. So what kind of tips would you have for someone in that position?
Yeah, sorry to hear that. That I guess that bolsters my original opening segue. Um, I mean, I would reach out to academic centers that are near you and say, I'm willing to do literally anything that you need me to do to help with your research. If it's data entry, if it's calling people, if it's whatever it is, because we all need it and we never know that it's around. Like in Philadelphia, we have access to like, literally six medical schools. And then if you go just over to New Jersey, which I heard someone is in like Newark, which is like 30 minutes from where I am right now. But it's welcomed. It is very welcome. I mean, we may not have something right now because we're in different phases, but at some point we will. And so any academic centers, generally speaking, if you can get to the division director or the fellows, I mean, the fellows are gold for this because they have to get research done to complete their fellowship. And if someone's willing to like do the grunt work, which is essentially what we would need, you could do that. And so I think that's an opportunity to, it's not really a cold call because you're in the field, you have interest in you're in medicine and you have an interest in OB. So it's really about finding mutual opportunities to be beneficial.
That's great. Thank you. I do have another question, but also if anyone in the chat has a question, please feel free to come off mute or type it in the chat, whichever you're more comfortable with. Maybe people are percolating on their questions, but my
No,
other
there's one
question,
in the chat that says, I'll read it. How would you recommend to start a project for a student that's a current third year? Um, I think finding current third year, you have like 6 months to get something out there. I would reach out to see what's potentially in progress because like I get to speak to the residents that I work with, like they're all in different phases of completion. And so if they knew that let's say they're on nights and they're like, oh my God, I'm never going to get to this crazy thing I have to get to. Like that's a place where you could plug yourself in and like just start helping. So I think that that's an opportunity. And then you have to recognize also that research can be done pretty quickly. Like if there's a case study, a case report, a cohort of cases, etc., like you can get those things done because there's no chart chasing you need to do. There's no data entry. There's very limited IRB, which I'm going to speak to next. So I think that those are certainly opportunities that you could hone in on. I'm certainly our research director, his name is Jay Goldberg. He was hoping to join us tonight, but he's actually on a plane, so he can't. But he is masterful. We put out, not exaggerating, on average, I would say 12 to 15 peer review published stuff every year. Our residents are always top three at ACOG district in poster presentations. It's our residents. Yes, they're amazing and they're committed and they're motivated, but Dr. Goldberg takes them through every single step. Sometimes they're annoyed by him because he's on top of them, but once they have that done, they are so appreciative. But you have to have someone like that because you've never done it before. You don't know the sequence to get it done. And so I guess I could put out there that I'm happy to connect this group because you're obviously highly motivated to Dr. Goldberg. He may not have something for everybody, but he wants people to be involved. It is what we strive for.
That's very generous of you, Dr. Jaspin. I think for anyone that is interested in taking up that offer, I would say maybe email NSS first, and then we can connect you with Dr. Jaspin. Does that sound okay to you, Dr.
Yeah,
Jaspin?
perfect. Yeah.
Okay,
So I
and
want to
we
talk
will
about, go ahead.
go ahead, go ahead.
I want to comment on IRB. So IRB should be a four-letter word. It is a struggle. It is difficult. I sat on the IRB, which I never thought I would because I couldn't stand it. But once you sit on it and hear and know the background, it kind of makes sense, like why it's so difficult. But it is a process. And for those who are in their third year and moving forward, I would submit that if you can't get something done, but you can get something started and you can speak intelligently about the process of going through IRB and how you were able to get denied and resubmit and come back and and understand like how to get research off the ground, that is very meaningful because that means that we don't have to teach you to do that. Like you know the process. And yeah, the IRBs are different in every university or every hospital, but the process is relatively the same. And so IRBs are really designed as protection for patients. And that's the truth. You won't think of it when you get rejected because you're going to think, what is wrong with my project? But nonetheless, it is important. And many of the things that you do don't require formal, thorough, complete IRB submission. So if you can frame your project as a quality improvement initiative, it needs IRB approval to be a waiver, but it doesn't require formal IRB approval. The difference being it doesn't have to go to vote. You don't need all the craziness. And it just has to be that you're showing that your project is not going to use identifiable information from the patient. You're not going to need to get into a chart and dig through for different people. It is going to be de-identified and it's a quality improvement project. What's an example? Crazy example. Who has ever gone to the operating room with someone whose BMI was probably greater than 35? Okay, true. And it's hard. It makes it more difficult for us. And they make these like expensive things. They're called tracks, TRAX. They are support the PANIS so that it's elevated and you can get better exposure. Okay, well, they're $50 a piece. And I'm like, I'm in a safety net hospital. I'm not paying that. Like, I'm not paying that. Why can't we? Because we were just taping people's PANIS up and it worked beautifully. And it was tape. There was no skin abrasion. There was no breakdown, nothing. So here was the study. When you tape someone's abdomen up, and then you put Hibiclens on top of it, and then you put a Tegaderm on top of that, does it increase the risk of infection? Okay. Well, then you have to go and say, like, how many infections do you need to have to power it right? And you have to do statistical analysis for which I'm like, I'm not doing that. So I said, well, what do I actually want to know? I want to know because they were claiming on the tracks that you open it in the sterile field. I'm like, okay, that's fair. But what if I put hippocampus on top of everything and do things I said? So here's what we did. This is so simple. We cultured the tape when we put it on the abdomen. You grew something. I know that's shocking. Okay. And then we put the hibiclens on, and then we put the tegaderm on top, and then we cultured it once we were on the sterile field. And guess what? It didn't grow anything. I didn't need to go to IRB for formal approval. Just had to go for a quality project. That's published. Like those are things that you can publish. So the way that Dr. Goldberg and I think about this, if you do something different, publish it or think about publishing it. If you conduct rounds differently, publish it. If you're going to change how you use interpreter services, publish it. If you're going to change how many people are on rounds and what's the patient's perception, publish it. There's an article my friend published. This is not false. This is a true, you go Google it. The doctor's attire doesn't matter to patients. Scrubs, formal wear, scrubs in a jacket, formal wear in a jacket, etc. Does it matter? Does that professionalism change? Does it change a patient's perception of professionalism? That's published, just so you know. Like that's what I'm talking about. Like it doesn't have and to me, those pieces of information are a little bit more important than like, I don't know. Should I use 25 micrograms of cytotec orally or vaginally? If the outcome is the same, like there's a hyperstim or tachysystole, okay, that's important. But at the end of the day, we already know that answer. I'm not going to like republish that. But what we don't know is a lot of the things that happen in an educational platform. That's where there's paucity of information. And that's where you can get that done. And people really like that. And ACOOG likes that, and ACOOG likes that. And those are major platforms. And if you're trying to get into this field, that's the place you got to go. And so I would really start thinking differently about what you're seeing every day and say, like, did anyone like we ever think about like who did someone publish that? Because that's what we do. That's all we think about. And we do publish it. So here is one that we did. And I'm telling you, this is like literally not rocket science. So we know that how quickly can you get someone from the delivery room to the operating room to do a section? So then is it a stat section, urgent section? Okay, fine. All true, right? So if you would think that if someone had an epidural that was functional versus someone who didn't have an epidural that was functional, from decision to incision, what do you think would take longer? Obviously, the person without the epidural. Okay, what if the person's BMI was higher than 60 and she didn't have an epidural, or they didn't have an epidural? What do you think? Take longer? Yes. Why is that important? It's important not because we prove the obvious. It's important because then you can say, wait a minute, this person's strip I don't really like. It has like intermittent, non-recurrent lates. There's a little bit changes in variability. I got to turn off the pit 3 times. The BMI is greater than 45 and they don't have an epidural. That's a stat section or an urgent section waiting to happen. Maybe we can talk to the patient about getting an epidural now. That's how you change it. And we know that to be true. And so we've published all that. And so then you can also do retrospective things. Where do you think is important about cord gases? If a cord gas is less than 7.0 and the base excess is more negative than -12, for those who don't know, that's not what we're going for. That means we missed an opportunity to intervene for that parent and that baby because the strip didn't tell us or we interpreting the strip. Well, how about this? We had done multiple elective repeat sections, and we send cord gas on everybody because we're an academic center. Like, well, we could eventually study it for something. So we realized that many of our elective sections who had a reactive NST in holding had a cord pH less than 7.0. No reason. So then we're like, wait a minute. Why? Why does that happen? And what can we use that information for? And so we started looking back at all of our cases that had a pH of less than 7, and how many did we emergently intervene on? And the answer was not as many as you would think. Because what do we know? We know that that strip that we all stare at is useless. If you were in the critical care unit and you told the intensivist, you can only look at the person's pulse, they'd be like, you got to be kidding me. How can I take care of someone just looking at their pulse? But yet that's what we do when we look at non-stressed or fetal heart rate tracing. Literally, that's all. That's it, period. And so it lies to us. And the reason it becomes important is because if you end up with a pH of less than 7 and a perfect strip, someone's going to say you missed something. Our data says not true. The strip doesn't always tell you the truth. And so we started thinking about it differently. And so I'm just putting forward to you if something when you're on rounds or if you're in the hospital, you're like, that's weird. go see if it's been published, because I guarantee you it's unlikely that it was published in the sense that you saw it. And it's not a case study, it's a quality improvement opportunity. So think about it in that way. I'll pause. Okay. Now I'm going to go to how do you write a paper? So I have a series of lectures on how to do this. And I broke it down as an anatomy class. Like, cadaver, remember? But I did it because we're OB and we only operate in the abdomen. I did it like, okay, so let's do a simple hysterectomy. What's the first layer? Skin, scarpus, da 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 da, fascia, whatever. Right? So when you start, you have to have an outline. You have to have an outline like you would for everything else. And you always start with materials and methods. And here's why. Um, if your materials and methods are flawed, the paper is useless. Here's what a paper really is. The introduction is you telling people what you're going to do, and your conclusion is telling people what you did. But if your materials and methods is flawed, why would someone care? Because it doesn't matter because your methodology is flawed. So researchers, not me, scientific researchers, they literally, when they go to read a paper, they read the statistics first, because if they don't believe the statistics, the paper's not worth reading to them. Then they look at the methodology, and if the methodology is reproducible and makes sense, and the statistics are right, they'll read the paper. And from an editor perspective, that I don't, I'm supposed to when I edit, like evaluate the statistics, and I can do it fairly well. But if I have a question, I just write in the notes, like send to statistician for further evaluation. But the fact of the matter is, you have to be crystal clear in your materials and methods. And so the way that I like you to think about it is, here's what your paper should say. This is exactly what I'm going to do, is your introduction. And this is exactly what I did. Now, here's where most junior writers get flawed. You like to write in your conclusions stuff that you wish happened, that you thought would happen, or that might have sort of happened, but then you go back and try to tie it to the statistics, and there's not enough information to tie them together. Paper never gets published. Because then it's like, I asked you to tell me what you're going to do, and then tell me how you did it, and tell me what you interpreted. And you failed in one of those assignments. And so you can only speak to what you did and what your statistician tells you did and what the statistics say the outcomes were. You can manipulate a lot of that mathematically, but your conclusions and your tables all have to be exactly right. And it has to tie together. And if you miss it, it's a problem. And so that is when you get into the more bench type of stuff, the more scientific type of thing, when we're doing like large cohorts of people, that's when we have to really be mindful of that piece. In other things, you can use descriptive statistics where you can just essentially speak to it, and it's a little bit easier. So having access to a statistician when you write your paper is imperative. Now with AI, everyone has access to a statistician, but the problem with that is you have to actually know what prompt to give AI. And if you're not in tune, you're going to give maybe a wrong prompt or get the wrong answer from the prompt and not necessarily know that it's incorrect. So it's a little bit of a problem, but it gets you further down the path than maybe it would have just 5 years ago, maybe 3 years ago. So I'm going to pause and I'm going to go to AI in a second.
Hi, Dr. Jasmine. I have a quick question. So if you were in our spot right now as med students that are looking for which programs we want to apply to, what questions would you ask programs to understand more about their research culture beyond what we could just find on a website?
Yeah. It's a great question. I would ask the residents, how do they get their research started? Do they have support for research? Don't ask them if they have time for research, because I don't know if that equates to outcome, because that doesn't, right? If you have time, doesn't mean you need to. So what's the support? Is it defined? Is there a research program? What's the output from the from the program in the past? Are there papers that I could look up? Things like that. Posters, presentations, etc.
Thank you.
Yes, of course. All right. So you guys are probably maybe not. I use AI fairly effectively, I think, because I don't know what I'm comparing it to. But it's relatively new for me. And here's why I was hesitant to use it. I felt like it was cheating. I felt like it wasn't my work product. I felt like it was a shortcut. And then we had a meeting with like senior leaders at Jefferson. It was really geared towards AI. And the CEO of Jefferson said, everyone in this room needs to be using AI every day. I was like, oh, okay. Like sort of gave me freedom. And so here's where it becomes a little tricky. What is your work product in research versus what is AI's? And we're working hard from the editorial committees. We asked the question straight out, did you use AI? It doesn't mean your paper's not going to get published, but it just helps us to sort of frame like where and how. We know people are using it. And on a very different topic, but for those applying, like you should be using it to help you with your personal statements. It shouldn't write your personal statement, but you should use it to help you because you have to put all the information in about what you want it to write. And quite honestly, if you put in like personal statement to go into OB/GYN, it's going to spit out a useless piece of information because you want it to be personal to you. And we want it to be personal to you. Totally different topic, but it's similar, right? So you can use AI to start your outline, to get your abstract started, but it should not be the entire product of what you do. Using it for research, using it to get you started, using it to comb through the papers that you've pulled about the particular topic and pull out like the Haitian Creole speaking patients. Just to do that's smart use of it. Like, why would you have to do what I used to read every paper? So I would use it in that way, but I would be forthright and say, yeah, I used it. And here's where, and keep note. This is where I used it. That's what you do. I'm going to share a story that's also published. One of my friends was the fellowship director for adolescent GYN at University of Washington in Seattle. And she and I were on this particular committee, whatever. And we were talking about like residents and their research that they submit when they apply for fellowship. And it was like some people would put in like they did like amazing papers. Like the titles were impressive. And so she wanted to call BS on it because she's like had a gut feeling there's no chance that so many people could do so much research in 4 years. And it's not really 4 years because there's no chance you're doing an internship year, maybe in your second year. So maybe in 2 years, right? So she had her fellows go back and medline search every one of the applicants for fellowship. 47% were fictitious. That's sad, sad. But no one checked it before. And so just know that it's not you on this call are going to do the right thing ethically, morally, but it's not a level playing field. So the reason I bring that in this context is if you're going to use AI, just say I used it. Here's where I used it to identify a body of people, a cohort, whatever. Say it, and then you're good. There's a guy who trained me in research. You can look him up. He's brilliant. He's retired. He was a statistician, OB/GYN, epidemiologist at University of North Carolina. His name is David Grimes. And he's the one who would tell me that he could read the New England Journal of Medicine, the Green Journal, and the Gray Journal all in one night. I'm like, dude, how do you possibly do that? He's like, because I just go right to the stats and they're generally flawed, so I don't have to read any of them. I'm like, oh, great. But here's what he says. He says, when you write a paper and prepare to write a paper, do exactly what you're going to do, put it out there in an outline, and follow it all the way through. But be prepared to change on the fly if the data that's coming in is against your null hypothesis. Like you want to just you had this idea based on like a gut feeling or a paper that you read, and if it starts to change, don't try to make the data fit what you thought. Allow the data to guide you to the place where the paper wants to go. And it was brilliant. Because so many times people are like, oh shit, oh sorry, oh shoot, my paper is going to not get published or I can't go forward because my idea is wrong. No, your idea got you started. Let's finish it now. And so I would just think about it that way. Throughout the last 15 minutes, I talked for 45 minutes. I could obviously continue, but I want to pause and see if there's questions. And at this point, it doesn't have to be about research. If it's about like residency programs, whatever. For those who don't know, the ACGME, which I was the chair of, oversees all education in the United States, North America, technically, arguably the world, for all fields of medicine. And it was an amazing opportunity to be in that position. But I honestly know about every residency program in the entire country, all 345 of them, whatever they are. And so if you have a question, please ask. I'm going to share with you before you ask that in reality, there are two types of residency programs. That's it. And you have to match the type of learner you are to the residency program you will best perform in. The two types of programs are preceptorship and hands-on from day one. They are equally efficient and effective. No matter which program you choose, at the end of 48 months, if you are good at what you do and take in and adapt to the training that's given to you, you will be an amazing OBGYN and you will be prepared for your qualifying and certifying examinations. The preceptorship is this, and you have to couch this by saying, which do you train best in and which will frustrate you the least? Preceptor is from day one, you can watch what I'm doing. We will talk about what I did. You will read about what I did. And then next time you will do a little bit, and then we will talk about it, read about it, and do it. And that works for some people because that's how they learn. And then there's hands-on from day one, which is, all right, we're going to the operating room to do a D&C, just as an example. Do it. I'm going to talk you a little bit through it, but like do it. So the frustration on one is, come on, let me do it. And the frustration over here is, how do you expect me to do it? I never did it. And so how do you learn and train? And then you can then start breaking it down. Yes, there's university. Yes, there's community. Yes, there's urban. Yes, there's all true. All true. End of the day, that actually doesn't matter. What matters is finding the place where you personally are going to be successful. And yeah, there's a component of it. Are you going to get along with the residents in the program? Are they like me? Are they people I can hang out with? That is probably the second most important piece. Maybe it's 1A. But those, as you start to think about it, don't get caught up in the name of the program, although we have an amazing program and a good name. But don't get caught up in the name of the program or the location, because that actually doesn't matter. What matters is your success in the program. Because if you want to be a fellow one day, you need someone from that program to write you a letter. And at the end of the day, you got to be successful to earn the letter.
Dr. Jaspin, I had a quick question. So I know you mentioned I might be jumping some trains here, but regarding conferences, how is it? How are national conferences versus local conferences, like presenting a poster or giving a talk? How is that viewed on your residency application?
That's an excellent question. So I'm going to tell you it matters a little. But the fact that you did something and finished it matters more. And so when we at ACGME, there's a requirement that every resident must do a research project. And research is loosely defined, to your point. A poster at a departmental presentation counts. And so every one of our residents presents a poster every year because we have a research day and they all like, right? There's prestige in the national, and then there's prestige at a podium, oral presentation, etc. But I wouldn't, that's more on a resident perspective. As a medical student, bringing something to fruition is an enormous accomplishment. And no matter, it does not matter where it is. It's an excellent question. Thank you for asking.
Thank you.
Sure.
As far as I'm a third year, but as far as like personal statements go for applying, any advice not to, I know they all kind of end up being somewhat stereotypical, but I had a preceptor recently say that her residency listed or read off everybody's personal statements after they graduated, and they all sounded pretty much the same. Is there any advice to on how to like approach a personal statement and maybe stray away from the stereotypical um, type of writing, I guess?
Yeah, Julie, I'll tell you flat out. Um, I've heard people at different graduations read the personal statements. I don't think I would never do that for our residents because they're deeply personal. To the point where I don't think I would share it. And so what I would never write, please never write a personal statement that tells me what I do or the residents do every day. Don't actually want to hear about your first delivery and how it changed your life, nor do I want to hear about, oh, it's an amazing field. I can take care of someone from, the first time they menstruate through their menopause. I don't care. I know that. I don't want to hear that you can go to the office one in the morning, the ER in the afternoon, the operating room in later afternoon, and the labor and delivery at night. I do that every day. I don't need you to tell me that. I need you to tell me what is it about the field that you bring and where your passion comes from. And that's what you need to do. What personal experience do you have that honed you into the person you're going to be? What aspect touched you that you want to be in this field at this particular time when it's very difficult? The residents who come to our program are very much into advocacy and reproductive justice and identifying opportunities for the underserved. And so there are lots of statements there. I'll share very honestly, I'm an athlete, played college sports. My family, same. If there's something in sports that you can tap into and say that like, doesn't have to be your whole, it should not be your whole statement, but there are lots of parallels in being on a team and being in a residency. Lots. Same for being in theater. It doesn't really matter if it's a sport. I just like to say that because I like sports. But it's somewhere where you had to rely on somebody else. They had to rely upon you. And when there was a failure, you picked somebody up or they picked you up. Like putting all that and all the other stuff into a personal statement, that's a personal statement.
Thank you.
Sure. All right, guys. Well, listen, you all stayed on the whole time at night. And this is it's very hard. I recognize that getting into an OB program it's very it's they all fill. Like literally the bad ones fill. The ones that are on probation fill. It's hard. Um, the letters that follow your name are no longer a problem. They are not. Um, Many people have paved the path for you. Um, but you have to excel. You have to. The problem coming from a school that is unknown in some parts is exactly that. I don't know what to expect from this student. Someone comes from Jefferson, like they've had 15 residents from Jefferson. Same from in Philadelphia from PCOM. Like they're at every major school. They're at Penn, Jeff, Temple, Einstein, whatever. But when you're coming from a school that's lesser known, you have to be exceptional in your interview, and you have to have research to show that you didn't just go to medical school and do 48 or 30 months at that point and then decide to apply. Like you did things. Leadership matters. Being in clubs is nice, but that doesn't, to us, very honestly, it means you went to get a piece of pizza one day and wrote that you went to a club. So if you're in leadership, that is meaningful. And not everyone can be in leadership, and we also know that. So um, your input as to how the club was formed, how the club progressed, what you did, all of it becomes important. But the research piece sets people aside because we all know, every program in the country knows the dedication, the perpetual commitment that it takes to get the research done. And so that to me is a competitive differentiator. So go for it.
Hi, I had a quick question before we go. Um, I wanted to ask, I have some research, but I don't really have a lot on women's health. Is that a detrimental factor when applying for residencies?
No, and I should have mentioned that. Absolutely not. And the fact that you have it is great. And the reason it could be for a whole host of reasons. That was where you ended up. That was the opportunity that came forth, and you wanted to take it because you wanted to learn the components of research, the basics of research, so that you could use it in your next step. No, we have residents who are going to go into ENT. I don't know why ENT overlaps with OB, no idea. But every year we have a couple of residents who are going to go on ENT, and all their research is in ENT. We don't actually care. They know how to do research. Okay.
All right, we have time for maybe a couple more questions if anyone has one before we wrap up.
Hello, Dr. Jaspin. My question is on, I am a third year medical student. I'm about to start my fourth year in the next 2, 3 months. In preparing and presenting myself for acting sub-Is or acting internships, how can I I guess, what would your advice be to put your best foot forward and show that you are a very good candidate for that sub-I or residency
Yeah.
program?
Great question. I will tell you that sub-Is are, this is just the truth. I'm just going to give you the truth, okay? Always will. Sub-Is are a double-edged sword. If you're great, great. But if you make one mistake, that's what they'll remember. And that's hard. It's not fair. It's not fair. But my response to your question is our residents love when people are helpful. And helpful could be there are 5 people in labor and 3 sections, and the second year or third year medical student wants to like ask questions, like when the residents are running around trying to admit 5 people. And so if that sub-I could take that student and be like, hey, let me just take you over here and talk to you about like why this is a variable versus a late. The residents would be like, oh my God, thank God for that sub-I. So, and then if someone pops in the triage and you go to the resident and say, do you want me just to get the quick history from this particular person? So, and I'll bring it right back to you. And they're like, oh my God, that would be amazing. Just tell me she's not dying. And then, so finding that place where that most help is needed is critical. That's part one. Part two is you can never get a question wrong twice. It's not acceptable. So if you get a question wrong, that's fine. But if someone asks you the same question later, and you don't know it, that'll show that to us is like that person never bothered to go look up the answer. And so in like our program is highly academic, highly researched. Most of the people do fellowship or like to do fellowship. So I'm only using my program as an example, but it's that would the residents would be like they're not interested in learning. So I would be on top of it every day, never be late, always be present, always be available. And here's the hardest part about being the sub-I. You want so much to be available and helping, but you also can't cross the line where the residents like, oh my God, they're everywhere and annoying. And every person, all 24 of our residents, 25, have different lines. So then how do you like figure it out? I don't envy it at all, but those are the places that the people who are successful, they learn to navigate that.
All right. Well, we're at the top of the hour. Um, Thank you, Dr. Jaspin, for speaking to all of us. I think we all have learned so much tonight. Um, really appreciate having you here. For everyone on the call, thank you all for joining us tonight. We are going to be having our next roundtable in April. We'll hope to see you all there. More information about that coming soon. Um, yeah, and we will plan to do more webinars as well. So we can see there's a lot of interest in research. So we would love to have you back, Dr. Jaspin, and maybe next time we can have Dr. Goldberg as well. Some more information on that coming soon. But otherwise, thank you all for joining us tonight, and we hope to see you
Good
again
night,
soon.
guys. Thank you.